Good evening, everyone, and welcome to the IR webinar series conducted by ICMR in association with IISc Bangalore. I'm Dr. Kavita Dhanashekaran, Scientist T from ICMR headquarters. So today we are in the sixth session of the webinar series, and we are going to learn about the study designs used in the implementation research. So to take us through this topic, we have with us Dr. Ganeshkumar. Sir is a scientist E, and he is heading the division of NCD Epidemiology at National Institute of Epidemiology, Chennai. It's an ICMR institute at Chennai. So welcome, sir. Thank you so much for giving your time for this webinar today. Without any further ado, I request you to proceed with your presentation.
Thank you very much, Dr. Kavita. Thanks for your basic introduction. Good evening, everyone. Happy to join with all of you in the sixth webinar series on implementation research. Today's discussion will be on implementation research study designs. I will briefly give you a kind of some kind of like an features available in MS Teams. You may see there is a question answer session is available in the feature is available. So one of the button in MS Teams, and also there is a chat is also available. You can post your questions in this chat or in the question answer tab. So without further delay, I'm starting this particular session, which is implementation research on study designs. In our previous sessions, we learned core fundamentals on what is implementation research, what is its context, what are its different applications on that, what is the specific implementation research, questions and objectives, and various implementation research programs currently being supported by ICMR. So in this particular session, focus clearly on what are the respective study designs which is used in implementation research. Before heading towards the area study designs, there are certain common terminologies which often provides uh, ambiguity, confusions, or in terms of like an various discussions and debate among the implementation research circles. I'm going to adopt some kind of like a common language related to these important terminologies of implementation research, which will be very useful in trying to understand the implementation research designs. The terminologies are what is called intervention, practice, or innovation, or even it is called program. Second is efficacy research. Third is effectiveness research, implementation research or science, implementation strategies, and implementation outcomes. When it comes to intervention or practice or innovation, or by say in terms of a program, what actually the last dictionary of epidemiology mentioned is that it is the intentional change on some aspect of the health status of the population. So intervention is an intentional change which is provided by, in a study setting, it can be an investigator, or in terms of a clinical setting by a healthcare provider, where it's an intentional change on some aspect of the health status of the population. For example, a preventive regimen, which is salt restriction in diet for hypertension prevention, which is an intentional change, is a salt restriction in the diet. For what? The health status of the population here is that is hypertension prevention or control of hypertension. The intentional change can be a therapeutic regimen. For example, here, provision of say like intake of amlodipine 5 milligram is an intentional change for improving the health status of the population, or intentional change on health status of the population is hypertension treatment. An example of innovation is mouth dissolving tablets for hypertension management. An example of a program can be like hypertension control program over a population uh, entirely implemented so that to reduce their high blood pressure. For ease of understanding, in this entire session, I'm going to adopt this intervention or practice or innovation or a program as we term it as the thing. This is a thing. Okay. Now, what actually we are going to do with this thing in the subsequent different terminologies? Efficacy research. Efficacy research is extent to which a specific intervention, procedure, or a regimen uh, or a service produces a beneficial result under ideal or controlled conditions. So ideally, if everything goes well, that's called that ideal conditions. Specifically, this happens in a research setting. The clear example here is effect of a fixed dose combination of metoprolol and amlodipine in essential hypertension, a randomized control trial. So this is a published study. So this is a specific clear-cut, what I say, like intervention, which is delivered for a beneficial result in an ideal or a controlled condition. For ease of understanding, the thing here is provision of fixed dose combination of metoprolol and amlodipine. That is a thing. And we are going to, what we are doing here in this, testing the thing in controlled setting. So I'm introducing this particular terminology. Efficacy research is testing the thing in controlled setting. And that thing here is the intervention. And that intervention here is fixed dose combination of metoprolol and amlodipine. Moving further, effectiveness research. Effectiveness research is extent to which a specific intervention, procedure, regimen, or service produces beneficial effects, same like efficacy research, but when deployed in usual circumstances of living on practice or real world setting. So in a real world setting where you are trying to deliver, you are delivering a specific intervention, procedure, or regimen or services in order to produce a beneficial effect. The example here is clinical effectiveness and safety of low cost versus innovator brand amlodipine in hypertension. Here you can clearly see it's a single blinded randomized crossover non-inferiority trial. This is a non-inferiority crossover trial, but it is applied in a real world setting in order to test the clinical effectiveness of that. Okay. So for ease of understanding, what we are trying to tell here is we are testing the thing. The thing here is what? Low cost versus that's a low cost amlodipine is the thing. We are testing the thing in a real world setting. So that is called clinical effectiveness research. The fourth here is implementation research. There are multiple definitions on that, but one of the definition which is widely accepted here is implementation research is a scientific method to promote the integration of the research findings and evidence-based practices into policy and practice, thereby improving the effectiveness of the health system. Very simple. Implementation research is bridging evidence to practice. For what? Improving the effectiveness of the health system. For what? In order to improve the health status of the population. So this is a simple understanding in terms of how implementation research is bridging an evidence to practice. Examples here is nurse management of hypertension in rural Western Kenya, implementation research to optimize delivery. So here, the thing here is nurse management. And how actually it's management of hypertension, but how better we are doing that particular thing is through delivery of hypertension care to nurse. So for ease of understanding, what we are trying to say here is we term it as how best to promote or help people or settings do the thing. The thing is hypertension management, but how best we are doing is to nurse management. Now we have to measure how best that nurse based intervention on hypertension management is improving the control of people with high blood pressure. So that's what that how best to promote or help the people or settings. The setting here is can be a clinical setting, it can be a program setting. do the thing, which is hypertension management. Implementation strategies, which is methods or techniques used to enhance the adoption, implementation, and sustainability of an intervention or practice or innovation. You all know now very clear intervention, practice, or innovation is a thing. Now, to enhance the adoption and implementation and sustainability, there are certain methods and techniques. Those are called strategies, implementation strategies. Synonymous, it is also called as implementation approach, implementation process, or implementation programs. More commonly, strategies. The example here is a community-based treatment strategy implemented by home care nurses would be effective in controlling hypertension. This is one of the hypotheses proposed by a researcher. If you clearly see here, the stuff we do to promote the people or the settings do the thing. What actually they wanted to do is delivery of hypertension care. What is the stuff, which is the strategy or the method or technique which we are introducing is community-based treatment strategy by home care nurses. So introducing a home care nurses is the strategy for what? For hypertension management to achieve control of hypertension, control of high blood pressure. So you can clearly see that the method and technique is home-based nurses for what? Enhance the adoption, implementation, and sustainability on hypertension care. The intervention and the practice is the delivery of hypertension treatment. So that is called the stuff we do to promote, help people or settings do the thing. Sixth is implementation outcomes. Here is that the process or quality measures to assess the impact of the implementation strategy. These are very, very clearly it is given in most of the literature that implementation outcomes are entirely different from the clinical effectiveness outcomes, the clinical outcomes. What we are talking when we are trying to mention implementation outcome is process or quality measures, which are like what is listed, some adherence, acceptability, feasibility, adaptability, fidelity, cost, and return of implementation strategy. All these are called process or quality measures. I give an example which gives a better way to understand it. In a study where they were trying to integrate hypertension reduction and management in HIV care, in HIV clinics in South Africa, they used a step-based cluster randomized effectiveness implementation hybrid trial. The implementation fidelity, which is an implementation outcome, which is trying to tell the process or the quality measure is adherence to BP measurement protocol. Please understand, in clinical effectiveness outcomes, what we will try to measure when we are introducing an HIV reduction and management program in hypertension reduction and management program in HIV care is control of blood pressure. Whereas here, the implementation outcome is adherence of BP measurement protocol by the clinicians or compliance of the patients on the treatment regimen. This is what we are trying to tell as adherence, or in terms of acceptability, whether HIV patients are acceptable that when they are introducing an hypertension management, screening, management, and follow-up in their regular HIV clinics. It's an acceptability. So this is what we will study in depth, something called implementation outcome. And if I just wanted to pull the previous definition, which is on the strategy is, there is a regular clinic which is happening, is HIV clinic care, and there is a focused group of patients who are taking drugs, antiretroviral drugs. We wanted to improve their hypertension control, blood pressure control. So let us introduce a program into it. This is a strategy, which means the stuff which we wanted to introduce in an existing setting. And what actually we are measuring here is that implementation outcome is that what is the adherence of the BP measurement protocol? What is the compliance of the patients on hypertension treatment? what is the acceptability of the healthcare providers in the HIV clinic in measuring the blood pressure. All these things are implementation outcome, which actually decides the success of the program. So for ease of the understanding, what we are trying to term here is how much and how well they do the thing. The thing here is that hypertension management for HIV patient. But how much and how well we are doing is one of the measurement outcome here, implementation outcome is adherence to BP measurement protocol, acceptability among the healthcare providers. This is our how much or how. Now you can clearly understand why the question, which is how, is clearly linked to implementation outcomes or implementation research. Moving ahead, uh, when do we do implementation research? So far, you would have understood multiple ways how implementation research, context related to that, implementation research questions, implementation research objectives. Now, when actually we are supposed to do that? You all understand that efficacy research is things works in controlled setting. Effectiveness research is things works in real world setting. And implementation research is things works by specific strategy, which is an implementation strategy. In other words, with an example of amlodipine and hypertension, when we say amlodipine reduces the blood pressure is efficacy research, which is in a controlled setting, what we are trying to demonstrate the efficacy of amlodipine on blood pressure. In effectiveness is amlodipine as a first-line therapy in a program setting achieves blood pressure control in 70% of the patients initiated on treatment. This is effectiveness research in a real-world program setting. Implementation research, the same example, amlodipine supplied at the doorsteps improved the medication adherence in at least 80% of the patients with high blood pressure. This is what I am trying to say as an implementation research example. The specific strategy is what? Doorstep delivery of drugs. And what is the implementation outcome? Adherence to the medication, at least in 80% of the patients, is what the expectation. So with this, you know that implementation research happens provided that we have sufficient evidence on efficacy, sufficient evidence on effectiveness. However, what we are going to discuss in this session is there is something called like where we will do effectiveness research and implementation research in order to expedite the evidence into the practice. And that particular thing is what I'm trying to give a picture here. In a usual relay race, effectiveness research is what the evidence we are generating on an intervention, which is passed on to an implementation researcher to take it forward for improved outcomes or improved delivery of health outcomes. In other words, when you are trying to link the strategy, how this can be expedited is what that the strategy which is usually done in an relay race is an exchange zone versus the fly zone. The same I am trying to give a kind of a comparison that an implementation researcher uses a strategy not to lose a relay race and also not to lose that baton and trying to finish this race ahead among the competitors. The same way is what an implementation research is takes the evidence from the effectiveness researcher, adopts a strategy to expedite it so that process and the quality measures are done much better to improve the success of the program. And in terms, it will improve the outcomes in the population. There is something called hybrid studies in the implementation research, which we are going to discuss largely. This is an upcoming science which has been discussed, and I acknowledge Kioran et al., which is published in 2012 and as well as in 2020 in Implementation Science Communications, and again in 2022, the research papers which introduced something, a concept called hybrid design and hybrid studies now. You all know this is the pipeline of efficacy research to effectiveness research to implementation research. Sometimes we no need to wait for an effectiveness research to complete in order to start an implementation research. Please try to understand that implementation research is the only way where you can wisely, scientifically answer that which particular strategy will deliver the evidence into converting into a policy or a practice, so that the expected outcomes which is already there on effectiveness research could be delivered much better. For example, we all know that clinical effectiveness of amlodipine, but what is the best way to make the drug available to the patient? The patients, what is the different? What are the strategies so that the patient is adhered to the treatment and achieves the control of blood pressure? And what are the strategies that we could follow up the patient regularly so that they are not missing the drug, they are not missing their blood pressure checkup, and they are not missing to check the complications related to high blood pressure. Still, we no need to wait for an effectiveness research. Even in the earliest stage, with an early stage of an evidence, we can still go ahead with an implementation research, and that type of arrangement is called hybrid studies, which combines the intervention effectiveness and implementation research questions in the same study. And this type of hybrid studies saves time. This kind of hybrid studies takes even an evidence at the earliest stage, demonstrate it, demonstrate the clinical effectiveness, and simultaneously demonstrate the implementation research outcomes, so that the wait time of an evidence to the practice can be expedited. That's the most important sole thing we need to understand. Okay. There is a difference of this implementation research trials and clinical effectiveness trials. What we do in clinical effectiveness trials is that we test the clinical intervention, for example, amlodipine, in reducing the blood pressure. What we do in implementation research is we test the implementation strategy. The example which I provided in the previous slide is that delivery of drugs at doorsteps, does it improve the adherence to the treatment or not? That is the implementation strategy. We are testing the implementation strategy in implementation research. The unit of randomization in clinical effectiveness trial is patient or a clinical unit. The unit of randomization in implementation research is it is a provider or a clinical unit or a system or a village or a geographical region where the intervention is implemented or the implementation has happened as a set. The unit of analysis in clinical effectiveness trial is patient. For example, if you want to demonstrate the reduction of systolic blood pressure by intake of amlodipine 5 milligram in 24 hours, our unit of analysis is the patient. We check the blood pressure of the patient. Whereas here in implementation research, the unit of analysis is sometimes provider, sometimes clinical unit, sometimes system. I'll give an example in terms of a clinical unit. We are introducing, say, like a strategy is pasting the treatment protocol of hypertension on the walls of the primary health center where doctors are sitting. This is a strategy. My assumption here is that by pasting a poster which is having a simple treatment protocol, the clinician will try to stick to that particular protocol, which is adherence to the protocol. So my unit of analysis is that I will try to analyze what is the number of clinics which has adopted the treatment protocol so that they are adhering to the treatment protocol. The primary outcome in clinical effectiveness trial, as I said, is the clinical outcome, which is blood pressure. Whereas in implementation research is adoption, fidelity, adherence. For example, here I mentioned this example of like the strategy as the pasting the treatment protocol on the wall. The analysis is that the number of clinics which has adhered to the at least 80% of the patients are treated as per the treatment protocol. And here is adherence is the implementation outcome as a primary outcome in implementation research. With this understanding, let us have a clear-cut walkthrough of what are the different hybrid studies, which is trying to link the effectiveness research, and the implementation research. I'm trying to bring again the same slide so that the pipeline of effectiveness research over the implementation research, how this could be combined in hybrid studies. So for ease of understanding, I made this a semicircle where one side is it's a spectrum where one side is the intervention implement clinical effectiveness research. The other is that implementation research. In this spectrum of a semicircle, what actually I'm trying to demonstrate is the hybrid studies. In hybrid type 1, there are three types: hybrid type 1, type 2, type 3. In hybrid type 1, largely, which is what we are trying to uh, test here, is that we are testing the thing here. The thing is the intervention. We are testing the clinical effectiveness of the thing, clinical effectiveness of the intervention. The example here is the effect of amlodipine in reducing blood pressure. Simultaneously, we also gather information on doing the thing. For example, how about when we are prescribing or introducing once daily oral dose in night before sleep as an intervention, as an implementation in this clinical effectiveness research. What we will be gathering here is that the information is whether the patients have some kind of an acceptability when we are making it as an OD dose whereas as BD dose, which means uh, 2 tablets in 12 hours apart or 1 tablet every day before sleep at night. We will try to gather information about what is the acceptability of such kind of a strategy, which is once daily dose. So this is the gathering information on the implementation is what the part we will be doing in hybrid type 1. The major thing what we'll be doing is only on clinical effectiveness. You may have a kind of a confusion little bit at this stage, but I'm going to show you a decision tree which will help you to choose how to choose hybrid type 1, type 2, and type 3. Hybrid type 3, I'm going to the other third extreme is that hybrid type 3. Here, what we will be testing is testing do the thing. The doing the thing is that implementation research. As I said, the previous example, doorsteps drug delivery for improving medication adherence. This is, I'm trying to test the thing. What I am testing here, the strategy. What is a strategy? Doorstep delivery of drugs. What is that testing that strategy? I'm trying to demonstrate an implementation outcome. I'm measuring that implementation outcome, which is called adherence to the medication among the patients. So the strategy is doorstep of drugs, and the implementation outcome is medication adherence. And that strategy is the stuff, is the doorstep of drugs. And what actually we are trying to do the thing here is that the delivery of the implementation strategy to improving the implementation outcome. However, we will also gather the information on the thing, which is called how many proportion of patients who are controlled by amlodipine 5 milligram versus amlodipine 5 milligram plus telmisartan 40 milligram. One drug versus two drug. This could happen even within the implementation research setting, which could be a secondary outcome. Fundamentally, when we are choosing hybrid 1 or hybrid 3, your primary objective changes. In hybrid 1, your primary objective is that in order to determine the clinical effectiveness of the thing, which is the intervention. In hybrid 3, your primary objective is how well or how we do the thing, which means whether the doorstep delivery of drugs, that particular program, how well we did. The outcome here is adherence to the medication. That is what the implementation outcome which we are measuring. This is just one example. There are multiple examples we can see. Adherence is one example, one of the implementation outcome. Fidelity is one more example, which we will be discussing in the forthcoming slides. Hybrid 2, which is mid pathway between hybrid 1 and hybrid 3, which takes some of the concepts of clinical intervention effectiveness research and as well as implementation research. Here, we will be talking both about clinical effectiveness and as well as implementation research outcomes. We'll be testing the thing and also we'll be testing the do the thing. The testing the thing, what we do is, we will try to see whether amlodipine 5 milligram single drug can able to reduce the blood pressure among the patients when it is given once daily. We will also testing do thing, which is in the same study, doorstep delivery of drugs improving the medication adherence. Please remember, this is something called co-primary outcomes, which means it's not only one, both actually plays important role. When we are supposed to do this hybrid type 2 way, we are going to have a decision tree to understand it better on this. And also simultaneously, we will be discussing little bit more on example, published examples of hybrid type 1, hybrid type 2, and hybrid type 3. So let's go ahead on that. Hybrid type 1, this particular study, which is published in American Heart Journal, where they are reducing ethnic and racist disparities by improving under-treatment, control, and engagement in blood pressure management with the health information technology, which is an hybrid effectiveness implementation pragmatic trial. Here, in order to make you too easy to understand, the objective of this particular study is to evaluate the impact of an electronic health record-based intervention on blood pressure control. To a simpler form, what is the effect of a digital health intervention in improving the blood pressure control? And simultaneously, if you see the title, they were trying to tell how whether it could reduce the ethnic and racial disparities. In this particular study, which is published, the intervention is electronic health record based intervention, which is introducing a digital health tool for managing the hypertension is the intervention, the thing. The clinical outcome is blood pressure control. So in this hybrid type 1, the primary outcome is that to evaluate the impact of or the effect of electronic health record based intervention on hypertension management to improve the blood pressure control, which is a clinical outcome. The testing the thing in real world setting is what they are trying to tell. Pragmatic intention to treat cluster randomized trial is the design they have adopted. Please understand, predominantly in type 1 design, hybrid type 1 study, we always adopt participant-centric or participant-led cluster randomized trial. We will be measuring our unit of randomization participant and the unit of analysis also will be the participant. Testing the thing in real world setting, which is an effectiveness trial. And also they are gathering the information on the implementation outcomes using a framework called RE-AIM framework, because here they are trying to answer the ethnic and racial disparities. So they are gathering the information on reach, effectiveness, adoption, implementation, and maintenance of the thing which is called the electronic health record based intervention, which is digital health intervention. And other implementation outcomes also this study is trying to measure, which is usability and acceptability and sustainability of this digital health tool. For example, we are introducing an app to a clinic. When we are introducing an app, a smartphone based app, what is the usability, acceptability, and sustainability of that? That also we will be measuring, which will be secondary. These are all secondary. What actually we are trying to do is that how best the EHR is implemented. We are doing the thing. We are trying to gather the information on that. When we are walking through two more examples, then you can clearly understand these important terminologies, which is the thing is the intervention, and testing the thing in real world setting is the clinical effectiveness, and how best to do the thing is actually the implementation outcome or the implementation research. Hybrid type 2. This study, which is published in Implementation Science Communications in 2022, which is hypertension treatment program, a type 2 hybrid trial by effectiveness and implementation interrupted time series trial. The main objective of this particular study here is implement and evaluate a large-scale hypertension treatment and control program in 60 primary healthcare centers through a type 2 hybrid effectiveness implementation interrupted time series design. Within this objective, they have mentioned the design also. You can clearly see that here it's an interrupted time series design where the adoption happens from one particular primary health center over a period of time. It's not like one at a go, interrupted time series. And sometimes when we are implementing in 60 primary public health centers, we'll be measuring in multiple time points. In order to understand better, you can clearly see that the program is the thing here. That is an intervention, which is large scale hypertension treatment and control program. Moving further, the design they have adopted is it's a type 2 hybrid study, which is a design is interrupted time series design. And they have selected as a pragmatic trial design. So they are testing the thing in real world. I already mentioned that what we are trying to do here is that we are trying to give a kind of a picture that we are in this particular large scale hypertension treatment program, they are introducing some of the strategies. One of the strategy is that financial strategy, where frontline healthcare staff are provided monthly stipends for registration of the patients. Here, the authors and investigators are all adopting a particular framework called REAIM framework, which is reach, effectiveness, adoption, implementation, and maintenance. They further measure the implementation strategy also. The implementation strategy in this particular hybrid type 2 trial is the stuff. What is the stuff? Provision of financial incentives to the community health worker or the frontline healthcare staff in order to do what? To register the patients. And they are giving monthly stipends, which is a financial strategy, is a stuff to do the thing in the large scale hypertension program. The core primary outcomes are the effectiveness outcome is monthly hypertension control rate, which is a clinical outcome. For that particular strategy, what I am trying to give you is different types of an implementation outcomes, which is mentioned in this particular paper. One is adoption. Of this, I mentioned REAIM. I'm trying to give only adoption. The adoption is that proportion and representativeness of the sites, which is the primary health centers, to initiate the hypertension program. The quantitatively also we could measure, qualitatively also we could measure. Please understand, in hybrid studies, it is not always necessarily that it is only trial, a controlled trial, or in terms of like a cluster randomized trial. It could be qualitative also. The example I have provided here for quantitative is proportion of primary health centers using hypertension patient registry. Now you know to answer this particular outcome, which is an implementation outcome, which is adoption is an implementation outcome, we may need to use the design which is cross-sectional, which is an observational study. The qualitative component of that where we have to use is some of the interviews of the respective stakeholders to identify reasons for the variations in the registry use among the primary health centers. In a large-scale hypertension program, there are multiple strategies are there. One of the well-tested strategies, WHO HEARTS package. In that, one important thing is that information system where they are introducing registries to register the patient and follow up the patient. They have to come regularly. So here in the implementation research, what we are measuring here is that what is the adoption of the hypertension registries in these primary health centers, and what are the reasons of variations in the usage of the hypertension registry, which is some are using, some are not using, some are filling, some are not filling. What is the reasons behind that? Here it is purely a kind of an exploratory qualitative study that we may need to use it. Some kind of an in-depth interviews among the participants we may need to use. And sometimes ethnographic studies also we are supposed to do at the clinical setting to see that are there any difficulties in usage of registries. And this is what actually we are trying to say is the implementation research part of it, which is the co-primary outcome here is the implementation outcome. One of that is adoption. How best the program is adopted to do the thing. This is a hybrid type 2. Hybrid type 3, the example here is that The one which is published in BMC Public Health, where our institution is involved in this particular. And I'm involved in this implementation research, which we are currently implementing. Community control of hypertension and diabetes in Kerala and Tamil Nadu. In this study, the main objective is to evaluate the implementation outcomes of peer support group program and community mobilization strategy. Now you know the thing here is the program, which is a peer support group program. That is a thing. And what actually the design we have adopted here is that hybrid type 3 trial. We are using 3 evaluation frameworks in order to evaluate the implementation outcomes in different stages. Re-aim framework, normalization process theory, and consolidated framework of implementation research. One such particular implementation strategy and outcome is what I am going to discuss it here of the hybrid type 3. Please understand, in hybrid type 3 trial, the primary objective is implementation outcomes, evaluating the implementation outcomes. In hybrid type 2 is its co-primary. We will be evaluating the clinical effectiveness also, we'll be evaluating the implementation outcomes also. Both we could do. And there are certain design considerations which I will touch upon to understand what are those design considerations into it. Here we are trying to answer the question, how best to promote the peer support group program in a community or a village to do the thing. The thing is that conducting the peer support group program. And what is the stuff to do the thing? In the peer support group program, I'll just give a brief understanding. Every month in a particular village, the hypertension and diabetes patients meet in a common place, which is led by a peer support leader and a community health worker, which is a mid-level healthcare provider. In this peer support group program, one of the strategies is that measuring the blood pressure and blood glucose in every peer support group program. It means every month there will be a measurement of blood pressure and blood sugar will happen of the participants. This is a strategy, which is a stuff to do the thing. Among this, the thing is peer support group program. In that, we are introducing a strategy. When we introduce a strategy of we will measure the blood pressure and blood sugar every month at free of cost, there will be more participation in the peer support group program. When they more participate into it, they will become more aware about this particular disease. They will clarify the myths related to hypertension and diabetes. The chances of or the probability of adoption to the medicines will be more, drugs will be more, adherence will be more, and subsequently control will be improved. And this will have a spillover effect also. This is the strategy, how it influences better deliver the thing which is called peer support group. I'll briefly touch upon the 2 important implementation research outcomes here. One of the outcome when we use a re-aim framework, the REACH. The quantitative indicator, what we are trying to tell here is the proportion of the people with diabetes and hypertension in the particular village enrolled in the peer support group program. And what we are trying to tell here is that reach is how best the program has reached to do the thing. And that is an implementation outcome. Similarly, the clinical outcome is a secondary here, which we are measuring, which is the control of blood pressure and blood sugar among the participants who are attending the peer support group program. In addition, we have an effectiveness outcome also in this particular hybrid type 3, where we are measuring proportion of the peer support groups, where at least 80% of the patients are under control. This is what actually we are trying to measure the effectiveness of the peer support group program in order to improve the control of blood pressure. As I said beginning, this clearly gives what is type 1, type 2, and type 3 hybrid studies. Now we'll explain how to choose which type for our specific research question. It depends upon the research question. It depends upon the existing evidence. It depends upon what actually we know better about that, all the terminologies I mentioned, which is clinical effectiveness, what we know about that implementation strategies, how we know about that adaptation of this clinical effectiveness intervention into their contextual setting, and as well as whether it is ready for a large level evaluation in a reasonable mature. I prepared this decision tree based on the Curran GM et al. Paper, which is published in 2022, the Frontier Cell Service, Reflections on 10 Years of Effectiveness Implementation Hybrid Studies. I strongly recommend this particular manuscript paper to read to better understand about this implementation, research, effectiveness, implementation, hybrid studies. Let's start with the clinical effectiveness data. The first step is that in clinical effectiveness data, is it weak or moderate to strong? For example, do we know that whether clinical effectiveness data on amlodipine for controlling the blood pressure, whether it is weak or moderate to strong? Assume that there is one new intervention where the clinical effectiveness data is weak. And in such cases, what we are supposed to do is type 1 hybrid trial. Even your clinical effectiveness data is not there, type 1 hybrid trial. You please remember or recollect that in the previous slides we mentioned in the relay race, the clinical researcher is handing over the baton to the implementation researcher. If the clinical researcher have not handed over to the baton, which means still that the effectiveness data is weak, then we need to do type 1, which is a clinical effectiveness trial is the primary outcome. In this scenario, assume that the clinical effectiveness data is moderate to strong. In such cases, we need to check on implementation determinants. Do we know about it or not? What I am trying to say in implementation determinants here is that what are all the important outcomes of this particular implementation research? Which means, do we have a clear idea that what influences or what determines that the adoption, what determines the adherence, what determines the fidelity of that particular intervention into that particular implementation, whether it is known or unknown. If it is unknown, then we need to do type 1 hybrid trial. Again, we go back to type 1 hybrid trial. If it is reasonably known, when I trying to say known means we have sufficient evidence on the implementation determinants on say adoption, fidelity, or adherence, whichever is the most important primary implementation outcome the investigator is trying to clinch. If the sufficient evidence is already available, then we move to the third step, which is how well we know about the strategies, which is the stuff. The strategies here I am trying to tell here is that the stuff is, do we know that which particular strategy will accelerate this particular intervention in order to reach this particular outcome? A given example, do we know how to make the medication adherence better? Assume there is already a published article, the clinical effectiveness data is there, that amlodipine is there already, which is a cheaper drug and as well as an effective drug. And second, we do have a clear-cut understanding about this, what actually influences the medication adherence, availability of that. That is the implementation determinant. A regular availability of that drug. And what is a strategy, which is doorstep delivery of drug. And for particular, that is a strategy which we are saying. That particular strategy, whether it is completely known or it is partially known, which means there is sufficient evidence in the example I mentioned, the doorstep delivery of drugs is actually improves the medication adherence so that the control could be achieved. If you see that tree, you can clearly link. If it is completely known, no, I'm partially know about it. There is not much of evidence in Indian setting, but there is a lot of evidence available, say like in an African countries, or a lot of evidence are available in Southeast Asian countries, but not available in India or not available in your state context. Then if it is partially known, then what you have to do is type 2, which is hybrid type 2 study. If it is completely known or it is like you are reasonably have a good evidence on these strategies, then we need go to the fourth step, which is the implementation adaptation. As there is already an evidence that doorstep delivery of drugs improves the medication adherence, and that actually improves the control of blood pressure. But do you have enough evidence or do you have the contextual understanding whether we could introduce doorstep delivery of drugs in our setting? If you don't have a community health worker, how can you deliver the drugs? That is called implementation adaptation. You may have some other community healthcare worker, but you don't know that how this could be adapted in your setting. Whether it is not known, whether it is little known, whether it is a lot to be done on that particular part is what I'm trying to say is implementation adaptation. Say, for example, the doorstep delivery of drugs, there is sufficient evidence available, for example, in Karnataka. You wanted to introduce in a state, say like in Kerala. Then one thing what we are need to ask, do we have sufficient evidence or contextual understanding or contextually whether that is feasible that to in order to adapt this doorstep delivery of drugs. Whether it is little required, some required or lot required, that adaptation is. If that is lot required, that adaptation is lot required, then you go back to type 1 hybrid. If it is some required, we do have some healthcare worker. All we need to know about it is that some implementation outcome and some clinical effectiveness, then you go to type 2 hybrid. It's only little required. We do have someone. Already they are doing some other services. For example, like there is already an ancillary worker who is going to the community regularly. And through them, that what we are trying to test is that whether the doorstep delivery of drugs can be done. Here it is, the adaptation is little required. In this stage, we are moving to the fifth step, which is called testing the evaluation readiness in real world settings. When we can do this, the evaluation readiness, you have reasonably implemented this program both vertically and horizontally. I now bring this example of India Hypertension Control Initiative. India Hypertension Control Initiative is started in 2018. It started in 5 states in 25 districts. In 2024, India Hypertension Control Initiative is in 26 states and 154 districts. Now you can see that both in terms of like an vertical and horizontal scale up has happened, and as well as over a period of time it is adopted into this particular health system, nearly 5 years. Now we have a reasonable, this is a learned important public health readiness which we need to answer here. It means currently it is having an evaluation readiness in a real world setting. It has reached a sufficient level of an maturity. And if it is partially known or it is completely known. If it is partially known, then you need to go for type 2. If it is completely known or it is reasonably it is known, then only you have to go to type 3 hybrid studies. In the previous example which I mentioned, you can clearly see that the type 3 design, where we have sufficient evidence on clinical evidence, we have sufficient evidence on implementation determinants, we have sufficient understanding on the strategies, we have sufficient understanding on implementation adaptation, and we have a considerably it is implemented over a period of time, we can go for a type 3 design. And these are the five important decision tree steps in order to choose whether it is type 1 or type 2. I know this is not so directly given in Curran GM et al. It is on 4 different types of questions, but I try to bring it together so that it will be reasonably understood with a stepwise fashion as a simple understanding when we need to go for type 1, when you go for type 2, when you go for type 3. Again, I wanted to clearly acknowledge Curran et al. And as well as I want to give an important indication. This is an ever-evolving science, and we are in a very reasonable stage. But this, I think, gives a better clarity on choosing the respective hybrid designs. Please remember, the usual research designs in order to test the effectiveness remains the same. Hybrid studies provides a kind of a platform on expediting or bridging the gap between the evidence to practice. The choice of research designs in hybrid type 1 study is if the primary outcome is clinical effectiveness, and all type 1 primary outcome is clinical effectiveness, it is participant level randomized control trial, which is a preferred. The regular standardized clinical trial is what the design to be adopted. You all know the randomization unit is participant, analysis unit is participant. We, of course, we gather some kind of like an information on implementation outcomes as a secondary outcome. where the observations can be qualitative and can be quantitative. A qualitative, it could be formative research in order to understand that how the intervention is being adopted into it. And quantitative is we can do a cross-sectional study whether there is an acceptability of this intervention among the participants or the providers into it. That's the hybrid. Still, we are collecting some information on implementation outcomes. Type 1 hybrid study also adopts cluster randomized and stepwise trial designs. They can also be used. In a cluster randomized, I give a simple example, not to give a broader thing. You all know that it's cluster randomized step design gives where we are, this example, implementation of infection prevention control policies by hospital. The randomization unit is hospitals, where some hospitals where infection prevention control policies through, say, like a specific strategy has been adopted, and whereas some of the hospitals is not adopted, which acts as a control. So we have an intervention clusters and control clusters. And in this, the unit of analysis is hospital, which is a cluster. And the outcome what we are trying to measure here is that proportion of surgical site infections reported by hospital. So that's a cluster randomized design, still can be adopted in a type 1. But majority it is a participant level RCTs, randomized control trials are the preferred designs. The choice of type 2 hybrid design here, as I told mentioned before itself, its co-primary outcomes, both clinical effectiveness and the implementation outcomes. I give a simple one important understanding that if your preferred choice is clinical effectiveness, then you go with the typical randomized controlled trial. Whereas if the preferred choice is an implementation outcome, then still you can go for a cluster randomized trial is the more preferred then, and your randomization unit is at the clusters, which is a unit, and the analysis unit is your clusters, which is the units of the clinics. So, for example, if my preferred design is say like preferred outcome is implementation outcome, then I need to enough power for the implementation outcomes rather than to power for an clinical effectiveness. However, with the overall understanding here, the implementation outcome, if it is powered well, the clinical effectiveness often gets the enough power in order to address the objective of clinical effectiveness. We could adopt, yes, there are many instances where observational designs and non-randomized trials can also be applied in type 2 hybrid study. But however, the concerns on the internal validity, reliability of the outcome measures, control over the exposure variable or the intervention, and the sample size issues really need to be addressed and should be taken care of. That when we are choosing these kind of observational designs or non-randomized trials, which includes pre-post, which I am going to talk in the choice of research design in type 3. Here, the primary outcome is very clear, which is implementation outcome. Your secondary outcome is clinical effectiveness, which will still you will try to study the clinical effectiveness for the same example I mentioned, the doorstep delivery of drugs. With the clinical outcome, still secondary we will be measuring is that the control among the patients before and after. And the implementation outcome, what we have been studying in that particular doorstep delivery of drug is adherence and adoption, medication adherence in that. So a single arm, a village level, the study which we published, the community level, community-based interventions is that a single arm pre-post village level peer support group program in order to improve the control of hypertension and diabetes. In order to vet that, please understand, in type 3 hybrid study is what most of the time, again, I'm saying is evolving science. It's not having a clear-cut thumb rule, but most of the time where you can do a pre-post design is in type 3. Either in type 1 or type 2, you need to go with a controlled trial. And here in this example, a community-based intervention, the implementation outcomes are the reach, which is participants, proportion of participants attending at least 80% of peer support group sessions. It's a quantitative. The effectiveness, proportion of peer support groups attained at least 60% of blood pressure control among participants. And the adoption is that proportion of peer support groups conducted as per the program standard. You can clearly see that some of them are quantitative and some of them can be done qualitative. For example, what are the reasons of barriers and barriers of conducting peer support groups in the village level at the community? Here you need a qualitative design in order to answer that particular question. So type 3 hybrids are necessarily powered to detect the effects and differences of one or more implementation outcome. Please understand, I wanted to bring that particular decision tree, and you can clearly see that type 3 is you have enough sufficient evidence on different types of levels, which is clinical effectiveness, implementation determinants, strategies, and as well as that your implementation outcome related to that implementation adaptation. So with this overall understanding of hybrid study designs, I give this a take-home message on these key terminologies. The thing is the intervention. Testing the thing is a controlled setting is efficacy research. Testing the thing in real world setting is effectiveness research. How best to promote or help people or settings do the thing is implementation research. Stuff we do to promote or help people on settings do the thing is implementation strategies. How much and how well to do the thing is implementation outcomes. And with this, the final take home message, I wanted to pull this decision tree when we have to choose type 1, type 2, and type 3 hybrid study in an implementation research. I hope so that there will be some kind of sufficient understanding on this implementation research design. I strongly recommend to go through these important manuscripts which is published, and throughout the presentation is what I have highlighted it, which will be really helpful to have a deeper understanding on that. Thank you, everyone. And if there are any specific questions, then I will pull out. I'll just check that what are the specific questions which is there in the either in on chat box or in question answer session. If there are anything, you may please post that in the chat box or the question answer, um, which is available in the MS Teams. Fantastic. I hope so. This is a ever evolving science, and this is very recently introduced concepts. Still in India, the hybrid designs, hybrid studies are yet to emerge more. In the past 10 years, only a lot of designs are hybrid studies are being published, even in the manuscripts, and little are known about that. So it has a difficulty in publishing thing also. But however, we are now having a good number of implementation research journals available, which has a better reviewers in understanding these hybrid studies. A simple thing is that these hybrid studies expedite and try to provide an opportunity to bridge the gap between evidence to practice. So I stop here. The time is 7. Already it's 1 hour has been we have been discussing about it. I would pull out the details of the next session, which is going to happen in the. You all will be received. Whoever is registered, receive the email of the link for the next session, which is the 7 in the row. I would request that if you could go through this particular thing. You can also check our ICMR website where we frequently give this announcements on future webinars. I would request to Mr. Solomon to pull this. Yeah, I think it's not yet live. Yeah, fine. Can you please share that on the screen? Yes. So the next session will be on application of frameworks and as well as some real world examples by Dr. Prashant, who is a director and a senior fellow of Institute of Public Health. Um, this will be happening in November 6, 2024. Post Diwali's, you can all join and see this. This is a very important session which clearly links whatever the terminologies we have discussed in this session and given more inner insights about different types of frameworks, how to apply it, and some of the real world examples in order to make all of you understand that. So with this, we close this session and we will wait for another couple of minutes if there are any questions which are coming up in the chat box or in the question answer session, question answer tab. Thank you. Thank you everyone for joining the session. And I could see there are no more questions coming. However, you can keep posting some of the questions in the chat box, which we could answer, because this is a kind of like an meeting chat, which will be available ever. You can also reach out to us. We will also provide some more clarity on this particular implementation research. Thank you everyone for joining the session. Have a great evening, and as well as have a great week ahead. Thank you. For this, we can officially close the session. But before that, I could see there is one question which has come up. Dr. Batma Priya, um, one is about to calculate the sample size for type 2 hybrid as it is co-primary, which outcome to take? Yeah, wonderful question. See, if your preference is implementation outcome, then you need to estimate the sample size on which implementation outcome you wanted to answer. If your preference is on clinical outcome, then definitely you need to you need to estimate the sample size on the clinical effectiveness. I don't know whether if it is possible for Godfred Dawson. Yes, I can allow Mike, Mr. Godfred Dawson. You may please talk now. If you could see whether you could talk. Mr. Solomon, can you allow Godfred Dawson? Allowed. It is allowed. You may please unmute and talk, Godfred Dawson. You are on mute, Godfred Dawson. If you have a question, you can unmute and talk.
Hello there.
Yes.
Okay.
Please.
Thank you for the presentation. It was nice. Thank you so much.
Thank you.
My question is after the workshop, the webinar workshop, will there be certificates for the workshop?
Certificates for webinars are not there, but thanks for putting this request across. We are going to introduce implementation research hybrid course. And in that particular course, where there will be a structured learning and there will be more interactive sessions and as well as one-to-one sessions will be there. In that, we will be providing a certificate of participation.
Okay. Thank you, sir. Thank you so much.
Thank you for that.
Welcome.
Thank you, everyone. And thanks for all your wishes. With this, we can close this session and have a great evening. And we will meet you all on November 6th, 6 p.m. on a fantastic another session on application of frameworks with some real world examples. Thank you.